But let me start by just quickly kicking off the program. We're deeply honored to have our first speaking guest today for our first plenary session of the day, Martha Minow, the Dean of the Faculty of Law here at Harvard, and Rebecca Onie, the CEO and President of Project Health. So let me actually start by just giving a very quick highlights of their biography. I know you had their biographies in there in your packet, so I'm not going to go through it in detail. Dean Minow is the Jeremiah Smith Jr. Professor of Law. She's been at Harvard Law School since 1981. She has been a profound scholar, produced a number of important works. Most recently, her latest book is In Brown's Wake, The Legacies of America's Constitutional Landmark, which was published this year. And after her appointment, I think it happened after your appointment as Dean of the Law School, she was nominated by President Obama to the board of the Legal Services Corporation, and that was a Senate-confirmed appointment that started in 2009. Rebecca Onie is, as I mentioned, the president and the CEO and founder of Project Health. And Rebecca started the Project Health in conjunction with, and I always get this wrong because of your donor, Dr. Zuckerman? Uh-huh. I always want to say Zuckerberg because somehow I have to change it from the guy who funds some of what we do here. Dr. Zuckerman, and founded the organization while she was a sophomore at Harvard College. She actually left that organization, I think with ambitions of, Supreme Court ahead of her as a lawyer, and she went to Harvard Law School, but found actually that after a brief stint in a prestigious clerkship, actually that wasn't her calling, and she returned to Project Health 4 years ago to take the reins of the organization and see it move to really amazing heights in the last 4 years. Rebecca gets embarrassed about this, but we were just talking a little bit too before the session about she's got this real inflection point that has happened in her career and in the work of Project Health. And I won't go down all the honors, but among the many honors she's received recently include receiving a MacArthur Genius Award, being a World Economic Forum Young Global Leader, an Ashoka Fellow. She received the John F. Kennedy New Frontier Award here at the Kennedy School not too long ago, and a number of other awards for folks who have had remarkable success early in their careers. So I think that you have a lot to go in terms of potential and amazing accomplishments, and I'm really looking forward to hearing a conversation about some of the challenges that you've both faced, the relationship you've had, and what that's meant to you. And we're going to actually try and reach around 10 o'clock. We'll try and do questions, but unfortunately, Dean Minow has a very tight schedule. So at 10:15, she's going to depart, but we're going to have a few more minutes with Rebecca after that. So please help me in welcoming them both.
Good morning, everybody. This is a fantastic group. In fact, there are very few things that I would get up this early and come to on a Saturday morning, but this is right up there. And I'll confess, it's to get a chance to be with you all, but chiefly it's because anything Rebecca asked me to do, I will do. Rebecca, I want to ask you to tell the Project Health story, but in a different way than you usually do. Let's talk about it in terms of warts and all. What have been the hard moments? And given what you're trying to do right now, how do you look back at its founding?
Well, first of all, it's a huge honor to be here. As Jeff mentioned, well, first of all, I will do anything Jeff tells me to do. So there's a bit of a chain reaction that's going on here. But as Jeff mentioned, when we were talking about doing this conversation or having this conversation, and folks at CPL were asking who have been great mentors, Actually, at the true top of the list was Dean Minow, who has been an advisor to me and involved in Project Health's work literally since 1996. Was my third year paper advisor when I was a student at the law school, and has just been a great champion and advocate and mentor to me. So it's just a privilege to be here, and I'm grateful for it. So the Project Health story, I know some folks in the room have heard this before, but when we were talking about it beforehand, I was saying how when I talk about Project Health's work, there's sort of the smoothed out story, which is the one that you share when you're doing speaking events and when you need to sort of move quickly on to the strategy of the organization. But, of course, the reality is that it's just always messier, infinitely messier than it appears. So the sort of brief version of the story with the warts is so my freshman year of college here at Harvard, I had signed up for an internship in the housing unit at Greater Boston Legal Services in the sort of belief that I was meant to be a lawyer, and that would be a good way to figure out whether that was in fact true. So, and really showed up my first day on the job completely expecting to make photocopies and coffee and all the things that I was sort of qualified to do at that point in my life, and ended up being paired with Jeff Purcell, a Harvard Law alum, who is just an amazing legal services attorney. And Jeff is crazy and angry and inspired all at once. And my first day in his office, he sat me down and said, Rebecca, I want you to call this landlord because there's these cockroaches in this apartment and I want you to get rid of them. Which I was, of course, like, wow, real work, real advocacy, and incredibly excited about it. And I said, that's great, give me the number. And he said, there's these cockroaches in the apartment, Rebecca. And I said, I know, there's these cockroaches, that's the whole point. And he said, I don't think you understand. There are these cockroaches in the apartment. And he kind of like put his hands out like a solid 5 inches apart or so. And I said, I know, I understand there's these cockroaches, I'll call. And he got up like right in my face and he said, I don't think you understand. There are these cockroaches in the apartment. And, his hands are now like a foot apart. And I said, okay. And he did it again and again until he got me really angry. And I remember distinctly, I remember where I was sitting, remember calling the landlord and saying to the landlord, I'm calling from legal services, you've got to get rid of the cockroaches in this apartment, I want you to get an exterminator out there. And this long pause at the other end of the phone, and the landlord saying, okay, we'll do it. And then I said, of course, but do you know how big the cockroaches are? But it was this amazing moment, I think, for me around recognizing how I could be an advocate. And that part of that was really having the facts, but part of it was also having the real fire in the belly. So basically, I spent about 9 months working at Legal Services and just having dozens and dozens of conversations with low-income families in Boston, and was struck by the fact that they would always be presenting with housing issues, but whenever you scratch the surface, there was always an underlying health issue. So I had a client who is about to be evicted, hasn't paid his rent, and you sort of say like, you'll probably be evicted if you don't pay your rent, and he explained that he was paying for his HIV medication. Clients that would come in, kid has asthma, wakes up every morning covered in cockroaches. And I just grew, fixated on this connection between health and poverty, but also really frustrated with feeling like we were just intervening way too far downstream. By the time families came to us, they were in crisis. So at the end of my freshman year of college, I read this article in the Boston Globe magazine about Barry Zuckerman, who was then and is still chair of pediatrics at what was then Boston City Hospital, big public hospital in Boston. And the article talked about how Barry had this kind of radical but also profoundly obvious vision that a pediatrics department should be a place where kids actually get healthy. And how he had assembled this dream team of non-clinical professionals to expand the scope of care that was being provided. So he had brought lawyers into the hospital to represent patients. He had brought grief counselors in because so many of the kids had witnessed domestic and community violence. And so this just powerfully resonated. And what's interesting is, so I called Barry at the start of my sophomore year, but in the sort of the kind of warts and all moment of the story, I remember at the end of my summer at Legal Services recognizing that I felt sort of compelled to start something at Boston Medical Center. I had no idea what it was at that point, but I remember knowing that I needed to sit down with Jeff, the lawyer I had been working with, and to tell him that I felt I needed to do this. And I was really anxious about the conversation because Jeff is just an incredible advocate for families. And it felt like, I was going to tell him that I was going to start a program for Harvard students. Like, I just remember thinking, oh my God, this is just not going to go well. And so sitting down with Jeff in the conference room in the legal services office, and I remember explaining that I had this idea, and I didn't really know what it was yet, but something about mobilizing other Harvard undergraduates to be able to address these non-clinical needs that patients had. And I was incredibly nervous about telling him this and just felt like he was going to think I was a complete sellout and not really interested in doing the real work in the trenches. And I remember sitting down with Jeff and explaining what I had imagined. And Jeff said to me in words that still hang over me, he said, Rebecca, when you have a vision, you have an obligation to realize that vision. You must go do this work. And I remember thinking all I wanted was his blessing. I didn't want the you must go do this work. But I really kind of carried that with me in times when the work has been incredibly complicated, this sort of Jeff in my head telling me you must go do this work. And just grappling with what does it mean to have a vision around the way the world should be, and the obligation to fulfill that even when it's the last thing you want to do. So just briefly, I did call Barry, Dr. Zuckerman, at the start of my sophomore year, and one of many conversations where I was mostly blown off, and told Barry that I thought he was doing amazing work, and also told him that I thought there was an important role for young people to play. And Barry said, why don't you go spend 6 months actually talking to some doctors and actually talking to some patients before you have your vision for the way healthcare should be delivered. And it's funny because Barry and I have talked about this since then. I'm always like, Barry, you totally blew me off. And he says, which I think is interesting, he said, I didn't blow you off. It was a test. He's like, I've told dozens and dozens of people that they should go talk to the doctors and patients. And they never come back. I never hear from them again. And he said, sure enough, 6 months later, you were there telling me what you had heard and learned. And he was like, it was a test. It wasn't a blow-off. And I was like, I don't know. It kind of seemed like a blow-off to me, but okay. So I ended up spending 6 months having these conversations with physicians at Boston Medical Center and just hearing the same story from them again and again. Basically, I would say, and again, no idea how to do a needs assessment or evaluation methodology or survey design, any of that, would just say to them, if you had unlimited resources, what's the one thing you would give your patients? And kept hearing again and again the same story in almost these kind of confessional tones where these doctors would just say, listen, every day I have kids that come into the clinic, kid has an ear infection or an asthma exacerbation, and I'm prescribing antibiotics or an inhaler, but I know there's no food at home. I know this family is living in a car, and I don't even ask about those issues because I just have no idea what to do. And I've had docs since then say, for those issues, we practice a don't ask, don't tell policy. And they just said, I have 13 minutes with each patient. Patients are piling up in the waiting room. I have no idea where the nearest food pantry is. And, I don't have any support to be able to deal with these issues. And that was really the genesis of Project Health's work, was a sense that, this isn't a system. This is complete chaos. And could we begin to mobilize a set of college students to be able to expand the capacity of clinics to address those unmet resource needs?
So you start the organization after, while you're in college, and did you think it would persist?
It's a really good question. People always say, how did you do this thing as a college student? And it was just, it was a student organization. I never would have said we're going to change healthcare delivery. It was a student group, and actually, after I had these conversations with doctors, this was about December of 1995, I realized that we probably did need and want to start an organization, or I needed and wanted to start an organization. And I mean, I was rejected by everybody. I mean, I went to Phillips Brooks House Association, which is the undergraduate service center, and they said, I don't know, we already have a health program and we have a law program, and you're trying to do both, and like, why would you try, like, just pick? And I was like, no, the whole point is it's integrated, it's multidisciplinary. And then I went to the Dean of Students office, and they said, we're not starting any more student service organizations. I mean, I talked to everybody, and finally, I mean, I remember actually crying about this, because I was like, how am I ever going to start this thing if nobody will allow me to poster on campus? Like, all I wanted to do was just poster on campus. And finally ended up actually at the Institute of Politics, who said, this is nothing like we've ever done before, but we think there's something here. So I think the idea was that it just wasn't intended to be big. It was just, could we get a small group of folks? It's interesting, because on November 8th, Project Health is about to launch a new name for the organization and a new brand identity, and this has been quite an intensive process. So we've been thinking a lot about the Project Health name, which we'll no longer be using. And part of the reason why we're not using it anymore is because it says Project Health, and it's not a project anymore. I mean, it's interesting, our logo, which some folks might know, actually the words Project Health like literally fade away. It's like, it looks like a stamp. And we've really come to say, we don't know that Project Health itself should necessarily last forever, of course, but we want our impact to be enduring, and we need a name that reflects that.
That's great. One thing that really always struck me is that your commitment to combining reflection with action. And can you describe a little bit how that has evolved and why you think it's important?
Sure. So Dean Minow is actually, Project Health, as part of our program model, has these weekly reflection sessions. So the volunteers spend 2 to 3 hours a week in the clinic connecting patients to community resources, 2 to 3 hours a week doing follow-up with their clients, and then a required hour to an hour and a half a week in what we call reflection sessions. And Dean Minow was our very first reflection session speaker ever. And it's interesting, I mean, so the genesis of it was mostly my college roommates who did this tutoring program really early in the morning, and would come back and we would have breakfast together, and they would just be so frustrated. They would say, gosh, like, I don't know why this kid doesn't want to learn. He's totally falling asleep. It's so frustrating. I'm getting up early in the morning to go out to his school, and he does, he's not even staying awake for it. And there was just no context setting. It was like, I don't know, did the kid have breakfast? Does he need eyeglasses? Is there a domestic violence situation? Is he sharing a bed with 3 siblings? I mean, there's any number of, sure, like maybe the kid doesn't want to learn, but there's any number of reasons. And it just felt so dangerous. Here you're taking young people and creating a context in which the main thing they're learning is that poor kids don't want to learn. And it felt just like incredibly irresponsible. And so, the notion behind reflection was to say you just can't be effective in your work unless you're grappling with the context in which you're doing the work and the parts that are hard about it. I think, on the flip side, our volunteers do real work, and that means it's frustrating, right? I mean, the food stamps application is impenetrable. Families don't follow through when they say they're going to follow through. I mean, there's so many parts that are hard, and I think part of being able to do this kind of work in a lifelong way is having the opportunity to grapple with what it really means to do the work in a lifelong way. And so I think what's interesting is about 4 years ago, Project Health finally said that we needed to name our organizational values. I, for years, had just been using the old, does somebody get it standard, which I was informed was no longer sufficient. And so one of our values is constant and courageous learning. And I think the idea is that innovation and efficacy flow most of all from learning, and that it's critical to have an organizational culture in which our learnings are celebrated. And that is something that has to be built in as a practice. It can't just, you can't just hope it occurs. You need to ensure that it occurs.
So you put it so well. There are these 2 dimensions of reflection as you've developed it in the organization, and one is to develop a bigger sense of the context and the larger systems and influences that surrounding the work. But the other is to provide a setting for the individual to vent and to maybe get some help. So how do you do that for yourself in your job?
Yes. I mean, I think one of the things that I am acutely aware of, really almost on a day-to-day basis, is that the probably greatest rate-limiting factor for Project Health is, as an organization, is my own ability to keep up with what the organization needs from me. I mean, we're moving so fast and so quickly. And if I can't keep up, I either need to know that so that somebody else can then assume the leadership of the organization, or I need to keep up. And so my learning is something that I feel like empowered to invest in it, because I think everybody understands that I better be doing it as fast as I possibly can. So I'm really lucky. I have, I'm lucky in a number of ways, but one is that I have actually an executive coach. So we're in Project Health is in the New Profit portfolio. I'm sure a lot of folks know New Profit. It's a venture philanthropy firm here in Boston, and we were selected into the portfolio about 3.5 years ago, and part of what you get is an executive coach. So my coach is a senior partner and monitor who works with like all the fancy Fortune 500 folks, but it turns out when he was a college student at Columbia, he connected folks at a soup kitchen with community resources. And we get together in person every month or 6 weeks or so and have a really intensive opportunity to reflect on what are the difficult conversations that I need to be having, that I either am or am not having, and just what is the next 3 months worth of my learning look like, because it's literally moving so fast that's kind of the relevant increment. And I guess what I'll say about Josh, who's amazing, and I mean, I'm my board chair I talk to my board chair every single week. He was my first investor, and he's a venture capital guy here in Boston. And I have a number of other folks. And I think what is most distinguishing about Josh and John, my board chair, and these other folks, is the fact that they are so invested in my leadership that they are willing to say to me the things I don't want to hear. And I think that is mentorship in my mind isn't just about encouragement or support. It's about really helping you grapple with your blind spots and really making you reflect on the parts of yourself that you don't want to reflect on. And the amazing, I think it's such a privilege to have folks who believe in me enough that they are determined that I am going to be the best version of myself, even when I don't want to. And so I think that's just a constant source of learning for me.
So you came back to the organization 4 years ago, and with the goal of building it and scaling it. So can you describe what's happened, where you are, what have been the biggest challenges, and what's the next 3 months?
So I came back, as Jeff mentioned, I had, after law school, clerked out in Chicago and then worked for about 18 months at a civil rights, community economic development law firm in Chicago, and realized that was not what I was called to do. And after much law school debt later, realized that was not, in fact, what I was called to do. So I came back to the organization, and it was interesting. My first year back was really, so I had left for 5 years, and the beauty of leaving for 5 years is you just get really good information when you come back, because nobody blames you for anything. Like, they're invested enough in your leadership that they want to tell you things, but they don't hold you responsible. So my first year back was just like, what is going on? And it was very chaotic because we were a nascent organization. Then the next year was when the New Profit investment happened and when our growth really began to take off. So where we are today is, so Project Health is now in 6 cities. We have 700 volunteers in those 6 cities, working with about 6,000 families a year in 22 different clinical sites. So pediatric outpatient clinics, newborn nurseries, OBGYN clinics, community health centers. About 18 months ago, we started a strategic planning process, because the thing is, so we had experienced enormous growth over the past 4 years. When I came back, the budget was about $500,000. This current fiscal year, which we just began, it's almost $6 million. But the question was, for us, should the next 4 years just be about more growth, right? And why, I know sometimes growth gets talked about as the end game. The organization's grown so much, that's so exciting, but I think it's to what end, right? And so we really wanted to grapple with that question, and basically through the strat process, said, our goal is not to just grow the organization. Our goal is to change the way healthcare is delivered. And so what would it take to do that? And in particular, what we said is, and really named and owned, which I think is sort of exciting and liberating in some ways, really said our vision is that healthcare will be redefined such that addressing patients' unmet resource needs, access to food, housing, childcare, will be addressed as a standard part of patient care. And specifically, that all clinics that serve substantial low-income patient populations will be screening those patients for unmet resource needs, and when those needs are identified, have some infrastructure to be able to connect them out to those resources. So that's become kind of our North Star. And the work has then, we sort of course, turned to the question of, great, how do we do that? And really try to say, over the next 4 years, what are the sort of levers we think we can pull to move the needle in that direction? And just very briefly, quickly said, number one, we need to really demonstrate that there is an effective and affordable model of clinic-based infrastructure that will create resource connections for families, that doesn't exist right now, and that would mean sort of testing our own family help desk model in ways we never have before at a much higher patient volume, and really trying to figure out, is there a breaking point operationally to our own model? The second is, part of our conviction is to change healthcare delivery. We need to change the leadership in the healthcare system. And our vision, I think, has always been that Project Health will be a transformative experience for our volunteers, and that it will have a profound impact on their career trajectories, and that they will go on to be leaders in healthcare broadly defined. But part of the work of the next 4 years is saying, okay, we now have thousands of our alumni. How are we engaging them as advocates, policymakers, vectors by which we can disseminate our program model? We need to really develop our theory on that and begin to execute against it. And then the third piece is, I think, just a recognition that if we're going to change healthcare delivery, we're never going to do it as a charitable program in the clinic waiting room. Like, we just can't be a nice nonprofit organization that runs some family help desks. We have to be delivering a sufficiently compelling value proposition that the healthcare system will pay for it. And so we're at the beginning of that work around framing up that case, but a real recognition that that's going to be a key element in really flipping the system. So in terms of the next 3 months, it's interesting. I mean, one of the things that's so hard right now about my role, I think in particular, but organizationally, is that we have these two powerfully competing demands. One is, we need to be a supremely effective organization. I mean, our whole case around that healthcare can be delivered differently is by our modeling that that is achievable. And so that means we have to have, a supremely effective program model. We have to be deeply integrated into our clinical partners. I mean, we just need to be executing on all cylinders. And at the same time, the healthcare landscape, as you all heard last night, and know, of course, is rapidly changing. So the challenge is, how do you build a robust program model and organization and pay the right amount of attention to that set of activities while the context in which you're operating is moving a million miles an hour around you? And that tension between, how do you not become so enamored with the context in which you're working that you forget that you're supposed to be connecting patients to resources, and that if you don't, you have no case? And at the same time, not so fixated on our new technology system and the nitty-gritty of that you look up 3 years from now and say, wow, like we're irrelevant. We totally fail to understand the conditions around us. And so figuring out how to spend, that's a question around how I spend my time. Mm-hmm. But also organizationally, how do we design ourselves to strike the right balance? And in an ideal world, you have this beautiful kind of iterative loop between what we're doing inside and what we're learning on the ground, and being able to communicate that back to the policy context or the healthcare conversation, social entrepreneurship conversation, and also being out there enough in that so that we can feed those learnings and insights that are emerging back into how we do our work. But that's really hard.
So let's talk nitty-gritty. You need outcome measures. You need metrics, both to make the case, but also to assess how well you're managing your organization. How do you come up with metrics that actually measure what you want and don't distort the kind of process that you want to have in place?
Yeah. So the million-dollar question or multi-million-dollar question. So I think, so the metric that we've mostly focused on to date has been one that's actually evolving for us, but has been, what we really look at is our success in actually getting the resource for the clients. So not did they get information about food, did they get food? And what's interesting is when I say that, folks are like, yeah, but like, what is the impact of that on their health? And I'll just say, as far as I can tell, very few organizations that connect anybody to resources measures whether they actually get those resources. I mean, one of the real challenges is there's actually not great benchmarking data for us, even around that piece of the equation. I mean, when you go into a clinic and the way this stuff is dealt with right now is that these incredibly busy urban clinics with literally tens of thousands of patient visits a year. And like we're in a clinic in Washington Heights in New York right now where there's one social worker for 47,000 patients. And that's pretty typical. So I'll tell you right now, that social worker is not doing data collection. They're not doing quality improvement. They're not tracking. They're not even able to follow up with their patients, let alone then collect that data, tie it to the electronic, the results in the electronic medical record, and then tie that in turn to the claims data for those patients. I mean, it's an utter impossibility. So just even the fact that we're and we are disciplined about documenting that question about the resource connection is, I think, itself more groundbreaking than, frankly, it should need to be, but it is. But then there is a legitimate question about, like, let's say, okay, you do get the family the food or the housing, so what? What are the implications for that? And what I will say is that the obvious thing is to say, well, what are the health outcomes that result from that? And I don't think we're going to measure that. And it's interesting, there's two reasons why we're not. And this may, whatever, everything always changes. So in 3 months, I may have a different answer. But I'm pretty confident we're not going to measure that for two reasons. Number one, I was talking with the head of a company called SilverLink, which does healthcare communications and has just spent a ton of time selling their disease management interface into healthcare systems and to payers. And I remember he's taking me aside about a year ago, and he was like, let me break it to you. No one cares about health outcomes. They only care about healthcare costs. So you can choose to go measure health outcomes, but it's going to be like the tree falling in the forest. So I thought that was useful. Like, that's good to know, but a little bit disheartening. But then about 3 months ago, we sat down we did this, Robert Wood Johnson Foundation is one of our funders, and we did this big evaluation session with them in New York, and we had 4 frontline primary care doctors sit down with us. 2 from Bellevue Hospital, right, big urban public hospital, huge immigrant patient population, and 2 from this clinic in Washington Heights that I just mentioned. It's affiliated with New York Presbyterian Hospital, large private academic medical center. And we asked them 2 things. We said, number one, tell us what is the data we would need to collect in order for you to be able to evangelize this model to your fellow primary care physicians throughout the country. And 2, what is the data you would need to go to your hospital CFO or CEO and make the case that the institution should pay for these resource connections? And they said, they were incredibly emotional, like literally emotional about it. And they said, do not spend a single dollar proving to us that when a family has food, it will be healthier. Wow. They're like, we are so tired of publication after publication telling us the things we know, right? We can see this in the lives of our families. And they were so outraged, right? They said, your mandate is to go figure out how this thing gets paid for, because that is what nobody's been able to figure out. So that's our mandate. So that's the question for us now is, really the sort of classic, what do we have to prove to whom question. In my mind, the whom is some set of payers within the healthcare system. It can be healthcare institutions like hospitals and health centers, which actually have started paying for our services. It could be Medicaid or Medicaid managed care organizations. It could be, the federally qualified health centers, the medical home dollars. But those, in my mind, are our audience, and what we now need to better understand is what is the burden of proof that we need to satisfy, and that's what I want to aim for. I mean, we'll do a whole set of evaluation related to quality improvement, meaning are we actually doing well the things we say we're doing? But separate from that, it's going to be about the payers.
Tell me, to whom are you accountable? And of all those different possible people, groups to whom you're accountable, which ones really guide your strategic choices?
Man.
We're back in class.
She said at the beginning, she's like, you can ask me questions too, and I was like, the role reversal, but clearly that's not going to happen. Anyway, a girl can dream. I mean, who aren't I accountable to, right? I mean, that's, I think, the hardest part of the job is being accountable to an infinite degree of constituencies. And what's hard about it, too, is with varying degrees of proximity to you, right? I mean, the one that I feel most acutely day in and day out is my staff team. When I came back to the organization about 4.5 years ago, in the national office, it was me and an admin, and then there was 4 local executive directors. And in the next few months, we'll have 40 staff, which, is teeny in the scheme of things, but is really different than 5 other people, yeah. Right? And my inbox is filled daily with hundreds of emails from them asserting pressing needs. We need a memorandum agreement with this institution. I'm unable to get my direct report to do the things that she needs to do. I mean, these very kind of urgent needs. And I think the real challenge is, I am accountable for them in the literal sense of I raise the dollars for their payroll each month. And so there's an acute sense of accountability, but that of course can't be the whole universe, right?
Can't define your life by your inbox, then you'll never do what you were supposed to do.
But man, that's so hard.
Tell me about it.
So the question is, who else, right? And so, I think we are accountable. The whole thing is premised on delivering what low-income families need, right? If we don't actually get them food or housing, what are we doing, right? We're spending millions of dollars and, sort of commandeering, literally tens of thousands of hours of staff and board and volunteers in this endeavor. And at the end of the day, if we're not doing that, it all doesn't matter. So that is an incredibly important constituency who are not in my inbox at all, ever. And then I think the other constituency is, so there's funders, but I actually am really lucky because I think a lot of our funders just want us to succeed so badly, they're pretty willing to leave us alone. In the sense of go do the work and don't spend time on me. But nonetheless, that's a key part. But I think the final piece is the health, the healthcare system is the constituency, right? The doctors in our clinics, the CEOs of the hospitals where we work, and then the policymakers. And I think part of what we represent to the healthcare system right now is the possibility, not just that our model might work, but the possibility that innovation could occur. And so part of our role is to deliver results, but part of our role is to deliver belief. Mm-hmm. Belief to doctors in the clinics, belief to the CEOs of these hospitals that they can deliver care in the ways that they set out to do. And that has some things to do with what actually operationally happens, but also has to do with how we tell them the story of our work.
So many of the things really worth doing, people say, are impossible, and what your job is to do is to show that it's possible. So let me ask you the personal question. This is a marathon, this is not a sprint. How do you sustain yourself? You don't have to get too personal, but how do you create an environment for yourself inside the organization, outside the organization, so that you get what you need so you can keep doing this?
Yeah. So it's interesting because, folks have been saying, almost since the first day of Project Health that I was going to burn out. And that, might happen, but it just really hasn't happened yet. I think it's kind of interesting, well, why not? So I think that, I think there's 2 things. One is I pretty much only work with people who I really want to work with. Meaning we just don't hire people into the organization who are not extraordinary people, where it just feels like a real privilege to work with them. I think some of you know Sonia Sarkar is here, who's my chief of staff and one of Project Health's alums, and it was Thursday, it was like 2 days ago, Thursday night. We're having our check-in call literally from 8:30 to 10:30 p.m. because that's just the way the day unfolded. And at the end, we were like, but I just love talking to you. No, I love talking to you. No, I love talking to you. And it's like, that stuff really matters, right? I mean, is there joy in the work because the people who you do it with are people you admire and respect and who challenge you? And so, and it's not just staff, right? It's our volunteers. We are incredibly careful in recruiting our volunteers, our board members, and also, and this is kind of interesting, but our donors. So about 2 years ago, I thought, I started just saying, like, what if we only worked with people, period? What if we only worked with people who we really wanted to work with? Like, what if we didn't take money from people we don't want to work with? Like, what if we didn't partner with doctors who don't really believe in what we're doing? And it's kind of, this risky thing of, can you afford to do that? Like, that seems a little like, I don't know, princessy, right? And it turns out it's incredibly powerful, because when you only work with people who really want to be in the game, first of all, what you're able to get done is just mind-boggling, but it's also deeply fulfilling. Like, I love our donors. I learn from them. They ask me good questions. They desperately want us to succeed, and that's really different than working with donors who are like looking for you to screw up so they can yank their dollars. And so I think that's one piece of it. The second piece I'll just say, which I think is really important, I think particularly for this crowd who are all deep in their own leadership work and many in the social entrepreneurship space, is the social entrepreneurship space is really a challenging space in I think a lot of ways. And there is this sense that you always have to be at the front of the room. Like, you're always kind of elbowing your way into the next donor, the next speaking gig, And when I came back to Project Health, I had a lot of ambivalence around this. I always hated the person who's like rushing the podium at the end, or like, the first person in section whose hand goes flying up. It was like, just like, give it a moment, And, but there's, in the social entrepreneurship space, there's a sense of, you gotta be at the front of the room. And I would go to these conferences where, like the CEO of Pepsi would talk, and literally people would be kind of physically almost jostling to like be near the stairs so they could ask her the one question that was gonna make her realize she had to give them $1 million. And so I had this real struggle around this, and I had this conversation with an advisor of mine, and I said, Rich, like, just be honest with me. He's been deep in the space for a long time. If I have to rush the podium to do this work well, just tell me that. Like, and I don't even know that I can do it, but just be honest with me. And he said this thing that was totally like life-changing for me, where he said, you don't have to be at the front of the room, but you have to be in the room. And I think that's totally right. And so I began this thing of like, what if I were just there doing really good work, being really honest about what we're doing well and what we're not doing well? Like, what if I just didn't fake it? Like, what if it were just all real all the time? Could anything actually happen, right? Like, what would that mean, right? And what if you only hired people you liked? What if you only worked with donors who you admire? I mean, like, that's, what if you created this weird alternative universe in which it was just all real? And that was about 18 months ago, and the past 18 months have been the most extraordinary 18 months in the history of Project Health. We found that when we were really honest with donors, they really wanted to fund us. And when people are always like, "How'd you get Michelle Obama to talk about you?" Or like, how'd you get in Oprah's magazine? And we've never asked for any of it. Like, we just kind of did our thing, and really, we're really honest and real about it. And I think the dividends have been amazing.
It's great. It's great. So let's open up for questions, comments. How do you keep going?
Hi. I'm curious, when you define the unmet resources for families, is part of your process to sort of push what those resources are? And are there controversial resources that you want to provide families that are difficult to get funders behind? For example, if a family is dealing with addiction for the parent, so just an example like that. Are you revising what the resources are that would address the health of a family, or do you stick with a core set that's proven that you know?
Sure. So we connect patients with what we describe as basic resource needs. So because our workforce are all college students, we actually explicitly do not tackle issues of addiction, domestic violence, child abuse, maternal depression. Those issues, of course, show up because you can't control where they show up. But our sort of model calls for that to become an immediate referral to the social work team in the pediatrics department. So part of our goal is to actually kind of rationalize how providers are spending their time so that the social workers who are trained to deal with those issues actually are spending their time on those issues and not on the work that we are doing, which is completing food stamps applications, helping families apply for fuel assistance, identify the nearest exercise program that they can afford. So we're dealing with a more I don't know how you would describe it, but a sort of a simpler and more basic set of resource needs, in some ways to then enable other providers in the system to tackle the next levels of difficulty. So we actually connect families to about 40 different types of resource needs. And to your question, we actually maintain information about those resources ourselves in-house. We have been eager over time to get more sophisticated in how we're able to do that and how we're able to understand the barriers that families encounter in accessing those resources. So we've actually just rolled out this fall to all of our sites a brand new database system, years in the coming, that allows us for every single resource referral that's made down to like an individual food pantry. When a family does not get the resource, what is the barrier the family encountered? So is it transportation, language, bureaucratic and administrative barriers? Was it that the family decided they didn't want the resource? Was it that we screwed up and didn't get them the resource? But part of what we will now be in a position to do is just an incredibly granular analysis, again, down to an agency level, but certainly at a community level, and then because we're in 6 cities, across those cities, around what do families need, what are the barriers they encounter in accessing those resources, and then I think sort of implicit in your question is there an advocacy agenda beyond that? And I think the tools of advocates are data and stories, and I think that we will be able to provide both of those with, we have been historically, but with even more precision.
Data is the plural of stories.
Thanks to both of you again for coming in on a Saturday. It's a bit daunting, by the way, to ask a question after Dean because you asked such great questions. But I'm curious about how you sell the story, since we're at HBS, of your organization and specifically how it's evolved. So, a lot of the interactions that you probably have are short encounters. And to tell a compelling story about an integrative approach that takes a holistic view is one laced with jargon like holistic and integrative that are difficult for a lot of people to understand. And then also it just kind of takes time. So and maybe this is going back too far, but if you could you speak about how your elevator pitch has evolved from when you were a college student to when you decided to come back to Project Health, and now how that might change with your strategic review and your rebranding?
That's an amazing question that nobody has ever asked. It's a great question. It's a great question. So number one, I never use those awful words, right? I never said holistic or integrative or any of those words.
Paradigm.
And actually, mostly never say social determinants of health, actually, which, it shouldn't be one of those, but it kind of is one of those. So it's a great question. I don't know whether, Sonia, you should think about whether you have thoughts on this as well, since Sonia spends a lot of time both hearing me do the elevator pitch and helping me think through what it is. So the number one thing is the story, right? No matter how little time I have, I always start with my own story. And I can tell it actually very fast. But the thing is, people love stories, right? And they love nothing more than a person's story, right? So I think that's number one. And it's interesting because at some point the question is like, do you outgrow the story of what you did when you were a freshman and sophomore in college? And I think that story has evolved from, I'll speak to that in a second. So one would think you abandoned that at some point in time, but I actually think it's a critical part of this because it both frames the need, the conversations I had with the doctors, but frames my own investment in it. The second thing is to just keep it incredibly simple. It's like, and so I actually didn't, because I sort of assumed folks knew in the room, but when I talk about the family help desk, what I usually say is, so doctors said they couldn't address these needs. our model is a physical desk in the clinic waiting room staffed by college students. When low-income patients come into the doctor's office and the physician identifies any unmet resource need that will have an impact on the health of her patient, access to food, housing, childcare, et cetera, the doctor has a prescription pad and can prescribe food or prescribe housing the same way they would antibiotics. The family takes the prescription to the desk in the waiting room, and our volunteers then fill that prescription. And the idea is like it's a virtual site visit. It's like you were in the clinic with me following the patient through. So I think the thing is to keep it very concrete. And the other thing is to use analogies without making the analogy. So the brilliance of, which we totally didn't realize, but the brilliance of the prescription pad for food is that everybody understands it. It's an incredible shorthand for the whole holistic intervention, right? I mean, it literally, when we say the doctor prescribes food for the family, that's the whole story right there. And everybody knows, they know what a prescription is, and it just makes it something that they can immediately imagine and relate to from their own experience. On the evolution of the story, so it's interesting. So the true, in the spirit of this being like a completely honest conversation, I think I have a very, and I think organizationally, we have a real humility around our work. I started as a college student going into a clinic, right? I mean, what the heck do I know? And so I think we have historically told our story in ways that really shine the light on that humility. A lot of we didn't know what we were doing, we didn't know how to do a needs assessment, really emphasizing the we totally get that we are outsiders to this system. And a lot of the feedback that I've gotten from folks who are trusted advisors who are willing to say the things to me that I don't want to hear is, Rebecca, like it or not, you're a leader in the healthcare space now, which is something that I have ambivalence around, right? But that's the reality. And so, you're speaking at the Mayo Clinic, you're speaking at, conferences the Robert Johnson Foundation puts together, and the emphasis that you can continue to convey a message that is humble and thoughtful without inadvertently undermining the power of your model and the sort of strength of your vision. And so the elevator pitch, I think, has gotten more confident over time, although I hope in ways that still reflect the fact that it is an integrated system and we are just a piece of that system.
No, I think I was going to ask you to say the prescription pad, because for me that is the most powerful. I do think that your ability to integrate the personal with the systemic is ingenious, because it's not about you. I think it is connected to the humility, but it's also connected to the innovation idea, because you're able to show you're still striving, you're still trying to figure out how to invent what the next element of this will be. And maybe there's a postscript or a next prescription pad, because you're now turning to the healthcare system itself, how healthcare is delivered, and you're prescribing something for healthcare.
That's good. Maybe I'll use that. The other piece is to rip off other people's good language about what you do.
I don't want to shortchange anybody else's question, but I wondered if I could ask actually a question of Dean Minow. How are you?
I thought I was going to get out of here. I know.
See, I was not going to let you get out without a question. How are you thinking about the law school as an incubator for folks like Rebecca, folks who have an idea, a theory of change, and want to go out and make that change and make sure that those folks get the education they need, the support they need, and are sent out in the world with the right resources?
Well, thanks for that question. One of the things that I did, I've been dean all of 15 months, so I'm a baby dean. But one of the things that I did very early on, even in this very difficult economic climate, is that I said I want to inject a much greater sense of entrepreneurship and social entrepreneurship, particularly in the law school. And so we've created a social venture fund, which starting with our current first-year class, when they graduate, they'll be able to apply for a startup grant. And we're not there yet, but just the idea of it has provided a kind of lodestar for the staff, for the faculty, and for the students. So now we're talking about, well, if they're going to apply for this in 2 years, what do we need to do? What do we need to put in place? And what kind of workshops do we need to have in place? How do we need to create new formal curriculum, informal curriculum? And it's led to some terrific discussions about the unwritten curriculum, the hidden curriculum. What is it that communicates to everybody that they ought to be getting ready to line up to interview at a law firm? And how do we create something that's comparable for some other kinds of opportunities? So that's just an example, having a very concrete program, but then using that as a way to reassess how the rest of the institution is organized. I think another example that I am struggling with is I'm very convinced that we're living in an inflection moment in the law, certainly, in the way that legal services are distributed around the world, in the way organizations are distributed, the way education occurs. And how can we be at the edge of that instead of followers is one of my big challenges, without losing what we do well, because we actually think we do something pretty well. And so how can I seed innovators, particularly around pedagogy, around global instruction, and at the same time not lose support for the core? That's a struggle, and I'd welcome any advice about that, but that's absolutely how I think about it.
And I'll just say one quick thing on this is, in some ways, what Dean Minow is doing is so radical. I mean, so the notion of a social venture fund is like, I mean, in some ways, this is what Harvard Business School has been doing and all these other folks. So so in some ways there's this version of like, well, sure, get on the bandwagon. But what's so radical about it is entrepreneurship is so profoundly outside of the way the law has been traditionally taught and even implemented. I mean, the whole premise of the law, and this is why I think I found law school so challenging and the practice of law so challenging, is because it's premised on precedent. I mean, it's premised on incremental change that accumulates over time, ideally in a direction that you want. And so I think to have this kind of explicit mandate of we want you to think in ways that are unencumbered by what has come before is just such a radically different approach to the law school experience.
Well, thanks for that, and thanks for your help in advising the fund. I do every day wake up with two phrases in my mind, and they both use the word leap, but in opposite directions. So one is, it's an old Hasidic saying, you can't leap a chasm in 2 leaps. No? And the other is a line from a poem by Adrian Rich, which is not like a leap, but each step making possible the next. And you just kind of have to have both of those, So with that, I got to go leap across the river to go to an event. Thank you all.
Thank you so much.
I really appreciate it. Thank you so much. Hi.
I still have to thank Dean Minow since she's here, but thanks for the very fascinating discussion. My name is Dave Calloway. I'm an emergency medicine physician, trained and practiced in Boston. Now I'm a transplanted Southerner. And I had 2 very specific questions, and again, I apologize for not knowing more about Project Health, but you seem to have made a strategic decision to go with primary care. The question would be, do you work with emergency departments also, and if not, why not? 40% of my population now is uninsured, and I can tell you every single day I come home frustrated because I tell a kid and the mom, here's a list of 20 primary care doctors. Sorry, I can't do more. And the other would be, within these groups you're working with, when you train them, when you educate them about these other outcomes and food and safety, how do you create advocates within the physician community within each of these institutions so they can carry on your work, spread them to other departments, so that you get the end result without having to actually dedicate resources?
Yeah, both good questions. So we actually are in, let me get the math on this right, 3 pediatric emergency rooms, Chicago, Baltimore, Providence. And you're exactly right. Point 1 is that still a lot of primary care happens in the emergency room. And emergency room physicians are, in many cases, essentially functioning as primary care doctors. And 2, that a lot of folks are still disconnected from a primary care system. So it's interesting, actually, at Johns Hopkins, we run 3 family help desks, 2 in primary care settings, 1 in the emergency room. And actually, the reason why the hospital is so invested in our doing this, and Hopkins actually is one of the few institutions that pays the total cost of all of our family help desk operations, is because part of what we provide in the emergency room, in addition to basic resource connections, is primary care connections. So actually helping folks, not just saying, here's the list of 20 doctors, hope it works out, but actually sorting them through the process of finding a medical home and a primary care doctor. So that's exactly right. I'll say, as you know, the emergency room context is a difficult one to do this work. And I will be honest that our success rates from an outcomes perspective are lower in that context, because there's just, you don't have the benefit of the longitudinal relationship with the client. We sort of piggyback on that longitudinal relationship. They're coming back to their doctor again and again, so we get to see them again and again. They feel like it is their primary care doctor is their home in some ways, and so our follow-up is more consistent with that clinical experience. So I think that's just a challenge that we're grappling with is, do you go, and this is just, a great strategic organizational question that gets played out in 40 different ways, but, do you go with where you're going to be able to hit it out of the park, or do you go with where the needs are? And they're not mutually exclusive, but how do you sort of design an organization so that you're effective, but also not effective simply because you're working in the conditions that are easiest in which to work? So that would be part 1. On part 2, how do we engage the doctors in the work or the providers? This is a huge part of the model. So I think there's 2 things. One is 65% of our volunteers are pre-med or intend to go into healthcare. So, we are like indoctrinating them right then and there. And we have these great conversations. We love nothing more than when we get these indignant emails or calls from our alums that are like, I just started my primary care, rotation or my continuity clinic. Where's my family help desk? Why isn't there a family help desk? And in fact, a number of our family help desks have been started by alums who were just like, I'm going to the top on this one, and we support them in that. So, and that's what we want. I think about that as creating consumer demand for our product. We want the healthcare system to be pulling our product in, not just are persuading people that it should be there. But in addition, there's all the kind of, meanwhile, the residents and attendings and nurses and other folks. And so we do resident education. We're built into the resident education, and we're I should say, almost exclusively in academic medical centers and federally qualified health centers. Those federally qualified health centers are almost all ones that are affiliated with academic institutions, so there are residents that are rotating through them, and we do build ourselves into the the noon conferences, the grand rounds, to be able to do this kind of education. I will say that probably the most palpable piece of the education, though, is that in the clinics where we operate, the doctors, which includes the residents, as well as the attendings, are learning to deliver care in the ways we want them to. So we actually launched in Baltimore in 2006 because back in the late 90s, when I was starting Project Health at Boston Medical Center, there was a resident there in pediatrics named Josh Sharfstein, who I then lost touch with. But 8 years later, right after I'd come back to Project Health, I got this very angry phone call from him, where he at this point had become Commissioner of Health in Baltimore, and he called and was like, Onie, where the hell are the family help desks? Why are there no family help desks in Baltimore? And he basically showed up on the job and was like, Baltimore has just devastating health outcomes. And he was scanning the landscape around what are the assets that we could bring to bear in addressing those. There are, literally like tens of thousands of college students in Baltimore. And we pulled off an incredible launch. It's one of our highest and best performing sites. We have 300 college students there who are now volunteering in 5 different clinical sites. And that's exactly what we want. His whole thing was, well, I don't know, this is how I learned to practice medicine. So when I became Commissioner of Health, this is how I thought the city should practice medicine. So I think that's exactly right.
Rebecca, did you want to introduce Sonia and maybe even invite her up to join?
As I mentioned, you should come on. So this is Sonia Sarkar, who, as I mentioned, is my chief of staff. Sonia actually was one of the 2 students who founded the Baltimore site in 2006. Then served through every leadership position we have for our volunteers, then became our program manager in Baltimore, which is the All of our volunteers are supervised by full-time staff who have case management or social work experience, and then came on about a year ago as my chief of staff. So it has an additional perspective on me and my leadership, as well as the organization. Probably nobody knows more about me than she does. Yes?
Hi.
Hi.
Thanks for the talk. I'm a primary care resident out in San Francisco, along with a few other people here. Writing a prescription for food sounds really good, especially the right types of food. I work with a lot of adult patients and getting them fresh fruits and vegetables in the neighborhoods there, and it's a safety net clinic is also just very difficult. My question sort of dovetails on the last one. It has to do with the community. One of the best experiences we've had in residency is when we've actually gone out into our communities and gone to some of these resources. A lot of it is around substance use, but a lot of it, a food pantry, community-based organizations, and just sort of interfacing with them. And my question is, have you, sort of your relations with the communities you work in, have you been able to get people in the community to come and work at the help desks as well? And just to build those bridges, both for the sake of people in the community being there so that there's more of a connection with patients. And I feel like when there's someone, sort of like the physician is able to, there's a good relationship and thus things will happen. I feel if people from the community are there, sometimes as opposed to college students, you're able to get stuff to happen. And the second thing is maybe some of these students going out into the community and actually going to these different places. And I'm sure that might happen to some extent, but just your experiences around that.
Sure, I can speak to the first. You want to speak to the second?
Sure.
So it's a great question around who is and who should be the workforce staffing the family help desks. We've grappled with a number of potential workforces. Obviously, we have college students, community members, retirees. Everyone loves to talk to us about the retirees and how they should be staffing our family help desk, the boomers. It's interesting. I think it's something we will continue to think about. When we did our strategic planning process, we really took on this question. And I think that so I think you're right. There's enormous logic to folks from the community staffing the desk. And what I'll say is even in the absence of that we are getting tons of feedback and input from our clients about what works, what doesn't work, and that information then gets incorporated back into our database, and that gets pushed back out to the next group of clients we're working with. A lot of our clients come to us because they were referred by other clients of the family help desk. But in terms of the specific staffing question, I think so the reality is that there's sort of pros and cons to any particular workforce. So the concept, of course, is that we need a group of sort of lay health workers, basically, who are supplementing the provider team in these clinical settings. And the question is, who should the lay workforce be? And we've just done, and I think, frankly, any number of them could do it. There's just assets and liabilities associated with each. And we've sort of settled on college students, at least for the next 4 years, for a number of reasons. But I would say a couple of the most critical ones are that we have real belief around this notion of the leadership pipeline, and that part of our theory of change is around changing leadership in the healthcare sector in sort of the more formal and traditional ways. And so being able to engage college students at that inflection point in their trajectories, we just want to churn out tons of folks that are going to go permeate the sector and bring the model with them. Community members can do that in some ways, but not quite in the ways that we're imagining. I think the second piece is, just around, it's interesting around who do patients actually want to talk to? And, again, I think there could be multiple versions of this, but part of what we've found is that the clients that we work with have said they actually love the anonymity and the accessibility of our college students. And the fact that they can go and sit down and say, I have no food at home tonight, and they're not looking at somebody they know, and they're also not looking at the doctor or the nurse who they feel like they need to impress in some ways. And this is just what families have told us. And so it's interesting. Again, I think it could totally work with community members, but I think that was a big learning for us, was that because college students are so accessible and not intimidating and have kind of limitless time to spend with the families, there's a rapport that they've been able to create. But I think, I think part of our aspiration for the organization is that folks look at it, explicit aspiration is that folks understand it as a model of there are ways to expand the capacity of clinics to address these resource needs, and if you recruit, supervise, train the right workforce and have the right technology backbone, that any number of workforces could do it. And our hope is that even if that doesn't end up being our service delivery model, that other folks would use it in those ways. Do you want to speak quickly to the resource thing?
Yes, I think you're absolutely right on forming these relationships with community resources. So in addition to the many assets of using college students as a workforce, one of the biggest ones is time, right? So college students just have time to go out and meet with organizations, meet with community resource leaders, all of that. So at each of our sites, we have resource coordinators and teams of volunteers that are actually responsible for forming those bonds and relationships with community organizations. And when I was in Baltimore, actually, I served as a resource coordinator, and one of the coolest parts of being in that position was that I was attending service provider network meetings. I was going out to big coalitions of organizations, and you just get this incredible level of detail that allows you to be that much more effective in referring families to resources. So for example, if we were referring a family to an immigrant services organization, our resource coordinator could go to that meeting and hear, oh, well, Sally actually doesn't work at the organization anymore. It's time for us to update our resource database and refer them to the person who is now solely responsible for getting our families in, and they're aware of Project Health, they're looking out for our referrals, and we can just be that much more efficient at tracking and following through with families all the way up until they receive the service. So it's actually a cool opportunity both for the volunteers, but also for the community resources to be brought into what's going on in the clinic and how Project Health is helping to facilitate all of those referrals.
I think we have time for one more quick question.
Hi, I'm wondering, given your legal background, if there's one law that you could change that would make your job easier, what would it be?
So I don't really have much of a legal background, let's be honest. I would say that so I think the thing that we are fixated on right now is what does Medicaid reimburse and what doesn't it reimburse. I think we can spend as much time as we want talking about the way the healthcare system should be, but at the end of the day, the healthcare system is going to be what's paid for by the healthcare system. And so I think, I say this with the knowledge that all of you well understand that, I think if we could be in a position where Medicaid reimbursed for connecting patients to resources, reimbursed for legal services that enable families to, for example, be able to negotiate with their landlords so that when they have asthma, they're not living in housing conditions that exacerbate that condition. That would be a radical change in the way healthcare is delivered. And the power of that is that it travels with the patient. In other words, it creates an incentive for institutions to provide those services because they'll be paid if they do that.
Rebecca and Sonia, thanks so much for joining us today.
Thank you.